Good morning everyone, my name is Georgina Sladden and today I'm holding an in-service that looks into the investigation of a coroner's report for the death of baby A. To begin, I'd like to give a brief overview of the case. Baby A died soon after his birth on the 8th of June 2008 at a Gold Coast private hospital. The cause of his death was found to be hypoxic ischemic encephalopathy due to meconium aspiration syndrome. The mother utilised water immersion during her labour, despite the risks associated with antenatal comorbidities and intrapartum complications. A coroner's report from December 2014 investigates this event. This is what we'll be discussing today. The event is will be discussed particularly in relation to discrepancies in the inadequacy of assessing baby A's welfare throughout the mother's labour. The purpose of this presentation is to reflect upon the happenings detailed within the inquest. A timeline-based approach has been utilised in order to methodically assess what took place during the antenatal and intrapartum phases of the mother's pregnancy and labour. Through doing this in-service will identify warning signs and critical incidents throughout, with analysis of midwifery actions and recommended alternative actions, reflective of current evidence-based literature and guidelines. A discussion around the appropriateness of water immersion in this case will be discussed, including comparison of the benefits, prohibitors, and risk factors associated. It is with the attention of this presentation that a better understanding around the importance of risk assessment and adhering to guidelines can be brought to attention, as well as uncovering how alternative measures could have resulted in an improved outcome for baby A and the family. Throughout the coronial inquest, there were a number of antenatal events identified where red flags throughout the mother's pregnancy should have been noticed and taken seriously. Antenatally, the mother had risk factors that put her within a high-risk category from the get-go. The mother is 42 years of age, meaning that she is classed as of advanced maternal age. The coroner's inquest doesn't discuss this as an issue. However, pregnant women who are of advanced maternal age have an increased risk of experiencing fetal growth restriction, preeclampsia, placental abruption, preterm birth, and stillbirth. These increased risks being independent of maternal comorbidities. This should have been considered in regard to the mother's labour and birth plan, as she may have required continuous fetal monitoring and have been disallowed for water birth, depending on the individual organisation's policy. If this was considered and the woman was counselled well around these risks, she may have been more inclined to accept continuous fetal monitoring during her labour. Another antenatal risk factor that presents itself within this case is the woman's ideology for the perfect birth. The coronial inquest suggests that the woman chose this Gold Coast hospital for the sole purpose of having a water birth. The birth plan stated that the mother wished to have a calm, natural, drug-free water, labour and delivery. This indicates that the couple were very firm on their wishes to have a natural birth as such. It can be seen how this ideology of their perfect birth might have tainted their perception of the overarching risk factors associated. Upon presenting this birth plan, it would have been an ideal time to counsel the woman on the risks of labour and birth in general and how it is important to be flexible with one's birth plan in order to prevent being disappointed or shocked later. It would have been beneficial to explain to her that there are many possibilities of how the course of labour can pan out and change. For example, some women may require more pain relief than expected. Some infants might require continuous fetal monitoring, and there are times when emergencies do take place that can indicate the requirement for a vacuum extraction, forceps, or a caesarean section, etc. By doing this, the mother will have time to think about it, and it will be less of a shock during labour if these interventions are required. The most significant risk factor throughout the mother's pregnancy was her preeclampsia. She was found at 36 weeks to have high blood pressure, along with borderline urates. At this time, the doctor did well to counsel the mother on water birth only being allowed in uncomplicated cases. However, the inquest does not confirm that he explained to her that having preeclampsia disallows her from participating in water birth. It is important to be clear with the patient in circumstances such as this in order to ensure that they understand the gravity of the situation. From here she went on to have her preeclampsia only increasing in severity. At 37 weeks, her blood pressure was 150 to 160 systolic, and on the 2nd of June, she was admitted to the antenatal ward with blood pressure of 160 systolic. She was commenced on labetalol around this time as well. The literature suggests that women who have preeclampsia can develop serious complications as a result. The literature suggests that women who have preeclampsia can develop serious complications as a result. Complications of preeclampsia can include fetal growth restriction, preterm birth, placental abruption, HELP syndrome, eclampsia, other organ damage, and cardiovascular disease. These developing conditions, as well as hypertension alone, can place significant stress upon the well-being of the unborn infant. Fetal distress resulting in hypoxia can be the cause of meconium-stained liquor as well, as the lack of oxygen and intestinal ischemia relaxes the anal sphincter, resulting in the passing of meconium prior to birth. The inquest identified that the cause of death for baby A was ultimately hypoxic ischemic encephalopathy due to meconium aspiration. It is fair to say that the reason for this could have been due to the woman's preeclampsia or obstructed labour, and that the outcome could have been improved if the fetus was monitored via external fetal monitoring throughout the duration of the labour to detect fetal distress and possible fetal hypoxia. A number of critical intrapartum incidents took place throughout the mother's labour that could have been better managed in order to improve the overall outcome of the birth. The discussed antenatal risk factors. A number of critical intrapartum incidents took place throughout the mother's labour that could have been better managed in order to improve the overall outcome of the birth. The discussed antenatal risk factors indicate that the mother should definitely not have had access to the bath during her labour. Furthermore, there were a number of intrapartum events that indicated additional contraindication for the use of water immersion and failure to comply with policy. The cascade of events that occurred on this day could have been managed differently, with the hope of achieving a better outcome. The first intrapartum incident that I'm going to discuss with you today is the appropriateness of the test done on admission. At 9 p.m. on the 7th of June 2008, the mother went into spontaneous labour, with contractions quickly increasing and membranes ruptured at 10:30 p.m. She presented to the hospital. Her blood pressure was 184/91 on admission. The midwife noted that the mother had a history of pregnancy-induced hypertension and was taking medication for this condition. The midwife should have collected a urine sample to conduct a dipstick assessing for protein urea. This sample should have been sent to pathology to assess the protein-creatine ratio. As well as this, a blood sample investigating the full blood count, urea, creatine, electrolytes, and urate, as well as liver function tests should have been sent urgently to give insight into the mother's condition. These results would have likely indicated that the mother was suffering from severe preeclampsia and required alternative management for this condition. Instead, a non-urgent blood test was sent to test liver function, which the results don't appear to have been chased up. Through these measures, the care of the mother could have been altered to possibly result in a better outcome. Another intrapartum incident that occurred was, upon admission, the midwife placed the CTG on the woman. It was applied for 20 minutes and it was deemed normal by the midwife, and not reported to the doctor when she phoned him to advise of the mother's admission. Upon retrospective review of this CTG, it was found that whilst tracing was not terribly clear, there is certainly a significant deceleration down to 90 beats per minute at 11:45 p.m. The CTG also showed reduced variability in heart rate. Furthermore, it was found that it was difficult to determine whether the baseline was 150 beats per minute with D cells or 120 beats per minute with A cells, up to 160 beats per minute. It was ultimately interpreted as late decelerations and therefore a non-reassuring and non-reactive trace, also known as a pathological trace. It is evident that the actions of the midwife in this situation were detrimental to the events that occurred thereafter. With proper management and recognition of this abnormal CTG, a better outcome may have been possible. The discussed antenatal complications and intrapartum incidents indicate that the mother should not have been allowed to enter the bath in the first place. In order to promote safety and standardised care, each facility has a set of guidelines that should be followed when offering water birth to women. This allows for scenarios like this to be avoided, as the guidelines are clear and act as an overarching legislative standard that everyone can follow. The Queensland Health Clinical Guideline for Normal Birth includes the use of water birth and is specific in identifying that water immersion and birth is only safe for natural spontaneous labour without antenatal risk factors. The RANZCOG warm water immersion during labour and birth guideline includes a number of recommendations for safe practice of water immersion during labour and birth. It discusses that rigorous protocols should be in place for candidate selection, infection control, and occupational health and safety procedures. As well as this, exclusion criteria recommending women leave the bath if urgent maternal or fetal compromise develops is essential. In relation to the case, the instability of the mother's preeclamptic condition would have been grounds to ask the woman to leave the bath. Had the mother not suffered from the discussed comorbidities throughout her pregnancy, water immersion during labour and birth may have been an acceptable and beneficial option for her labour and birth. Normally, water birth is deemed appropriate for healthy women with uncomplicated pregnancies. In these cases, water birth can be very beneficial as it can aid in relaxation, assist in the production and release of endorphins, and reduce the requirement for pharmacological methods of analgesia and the associated side effects. As well as this, water birth can reduce the pain of contractions and pressure on pelvic muscles. It is clear that there are numerous benefits, prohibitors, and risk factors associated with the use of water immersion in labour and water birth. As is common practice in midwifery, the key is adding up the risks versus the benefits to determine what is best practice. There is certainly a place for water birth, however, with comorbidities such as preeclampsia or meconium liquor, the risks of complication outweigh the benefits that water birth can potentially provide the woman. In summary, this presentation has given insight into the coroner's case of baby A through discussing the individual events that occurred, which are believed to be detrimental to the outcome of the case. In summary, this presentation has incidents included the lack of recognition that the woman was of high risk and therefore ineligible for water immersion in birth, the lack of adequate assessment for severity of preeclampsia upon admission, and the lack of recognition of abnormal CTG trace upon admission, as well as the lack of recognition throughout the labour that the bath was unsuitable for a high-risk labourer, such as the woman. A number of alternative midwifery actions were recommended, in accordance with clinical guidelines and evidence-based literature. The benefits, prohibitors, and risk factors associated with water immersion and birth have been discussed, and have identified that water birth was contraindicated for a number of reasons in the discussed case. In conclusion, this presentation has indicated that a better outcome for baby A could have been possible with appropriate clinical action and recognition of complications.